went so far? Stop and ask. Any of the previous lectures? Okay. All right. So diabetes is all about glucose metabolism, and it's pretty straightforward from a pathophysiologic point of view, I think, but I'll leave your other professors to make it more complicated than I'll make it. Basically, too much sugar, we want to get rid of sugar. It's pretty much what I think about, and we have drugs that do that. So there's lots of different pathways, and your body stores glucose differently, and there's lots of different organs involved, and I'll talk about that with some of the mechanisms, but again, I don't want to get too much into that with this particular lecture. So why do we care about treating diabetes? Well, it sort of goes hand in hand with a lot of other diseases that start off not super problematic unless you have type 1 that can be serious right away. But for example, with most patients with type 2 diabetes, they aren't going to notice any issues right away. It's kind of like high blood pressure, where it's not necessarily a silent killer, but it over time causes damage in the end organs. So people get increased risks of cardiovascular issues, stroke risk goes up, eyesight gets poor, kidney problems, neuropathies are kind of the more common ones. And then you couple that with some other metabolic things we've talked about already, like high cholesterol, high blood pressure, and then you have a really bad picture, especially from a cardiovascular risk factor. So that's the purpose of treating this. Let's start and talk about type 1 diabetes first, and we'll talk about all the insulins and then go into type 2, talking about the oral medications. So type 1 diabetes is going to be one of the more common chronic diseases affecting children. It is an autoimmune disease, so basically your insulin-producing beta cells are slowly destroyed over time. Your body can't make insulin, so therefore type 1 is also often referred to as insulin-dependent diabetes. So if you haven't had much of this so far or don't know much about diabetes to begin with, the big takeaway between the two is type 1 patient is always going to be on insulin. You can't manage type 1 without insulin, and you can't manage type 1 with oral medications either. So that's the big difference between the two from a pharmacologic point of view. I don't really care you know this, but I think it's interesting if you look at trends across the world and where type 1 diabetes is most prevalent. It seems like people with European backgrounds tend to have more so than other areas, which I think is, again, kind of interesting compared to like Southeast Asia. Onset, it's kind of important, especially if you go into pediatric medicine. Otherwise, it's not a really big deal, I don't think, for most of us to know this. But it seems like there's two kind of pools. Kids will either present with onset around 4 to 6 years of age or 10 to 14 years of age. Your pancreas has quite a few beta cells to produce insulin, so it takes a while for the autoimmune disease to actually kill enough off where you're going to see effects. So that's why there is that delay from birth to the onset of the disease. And I don't know if some diseases is more significant or not, or why there's that big gap. That tends to be the two major time periods you see, or age periods you see the incidence. About half of those people present before 10, so it's about 50-50 split between the two there. And then again, just stuff I think is interesting, nothing really testable here. In case you want to look at genetic susceptibility and what the percentages are, I put that in there for you. Because again, I think this is a very unexplained disease as far as what happens. And so there's lots of testing and epidemiologic studies as far as how we can pinpoint if people are at higher risk or not for type 1 diabetes. This is a pretty complicated disease to manage over time. It's straightforward from the perspective where you're just supplementing insulin, but it's hard on the patient. So, symptoms of onset, really going to be the same for either type 1 or type 2 diabetes. Most patients are going to just present with increased blood sugar. And so polyuria, polydipsia, and weight loss are kind of the three common things you're going to see. So really it's just the body trying to, polyuria, excrete extra glucose. So it's trying to get rid of glucose by filtering it out through the kidneys, which over time can damage the kidneys. Polydipsia, increased thirst, and this is really just to increase, because of increased serum osmolality, your body's trying to increase fluids to dilute out the sugar concentration. And then weight loss just has to do with some of the other aspects as far as how we're metabolizing different nutrients, and you might get some nausea and anorexia in other cases. Okay, so for insulin therapy, again, required for all patients in type 1. You can certainly use it in type 2, and a lot of type 2 patients will end up on an insulin regimen of some sort, but it's not the first line for type 2 patients. Your goals, we really just want to prevent long-term complications, and if you treat type 1 diabetes correctly, you really shouldn't have a lot of long-term complications. It does require the patient to be pretty compliant, though, and have good adherence and good access to caregivers if they're a young kid, especially, or an older adult even. There are a lot of different insulin products available, which makes it a little bit confusing. We'll talk about some of them, and I'll sort of tell you how I want you to categorize them for the purpose of my exam. And then finally, there are insulin pumps, continuous infusion pumps, which are an option for patients in this category as well, which we'll talk about. All right, so pre-treatment considerations. There's a couple different strategies that have been used historically. Conventional has sort of fallen out of favor. It's a single or twice daily injection, and really it doesn't mimic physiologic insulin production enough to be effective for a type 1 patient. So we really don't use regimens that only involve 1 or 2 injections, just because what are you going to do about your mealtime spikes that you would normally get? You don't really have anything to cover that. So the only time I ever see a conventional-esque regimen used is for cost control. So if you have a type 1 patient who really can't afford it, and all they can afford is, we'll talk about NPH and regular insulin, but those are cheaper. They might do a couple times a day of that versus a more complicated regimen because of cost. But at the end of the day, we should be able to hopefully work with social work or whatever to get them the most effective treatment for them, which is going to be more of an intensive regimen. So this is supposed to mimic physiologic insulin. And so essentially the backbone with an intensive regimen is you have a long-acting insulin on board that's reactive to snacks or whatever like you might take. And then you have mealtime insulin. And most patients do carb counting or sliding scale, or they might take a fixed dose. It kind of varies, but that's essentially the breakdown between the two. So it's much more like what our physiologic insulin would be in a person without diabetes. It is more intensive effort as far as the patient's going to have to do more injections. They're going to have to measure blood sugar more often. The higher risk of or the increased amount of insulin you're taking, every time you inject insulin, there's a risk of overdoing it and getting into a hypoglycemic state. So that's something we want to watch out for as well. And then increased costs. So usually you're looking at a couple different types of insulins combined in a regimen, which is going to give you added costs, sometimes out of pocket for the patient. All right, insulin, I think some people might think of it as, drawing out of a vial and injecting, and that's certainly the case in some aspects, but that's pretty much gone now. We use mostly pens, and pens look like this. The nice thing about an insulin pen is that it has a little window on it with a unit counter on it. So you can just, this little thing on the back that you can see this person holding, you twist that, dial that up to the number you want, you inject, you click the button on it, and then it injects that amount automatically. Each insulin pen has about 3 mils of insulin in it, which most insulins are 100 units per mil. So you get about 300 units per pen. So that's just, we'll talk about that again, but just in case you're curious now as to what type of volume you're working with. Usually there are more concentrated formulations too. So for patients on really high doses of insulin that we might see occasionally, that is more convenient for them because they can inject a smaller volume. Your subcutaneous tissue can only really hold so much liquid in one injection before it kind of just rolls out. Or if you've ever tried to inject have you guys ever done a lab where you've done one of these by any chance? Anyone? Okay. If you inject more volume into the subcutaneous space than it can hold, it'll just kind of beat up and roll out of the area. So you want to make sure that you're giving the appropriate volume, and so sometimes those more concentrated products are beneficial. But most insulin pens, essentially, they're all designed exactly the same way. They have a window. The one downside to them is they don't tell you how much is left. You can look in this clear part and see kind of how much liquid is left in there, but it doesn't tell you like on the counter how many units you have left, in case you're wondering. So it's not like an inhaler where it sort of counts down. This is just dialing up the dose. Right, a couple different categories of insulin. There's basal insulin, and this is what we call long-acting insulin. So it's pretty much a required option for patients with type 1 diabetes, and there's 3 products on the market, Largine, Detamir, and Degludec, and I'll talk about some of the differences here in a second. For this class, I really just want you to think about them kind of all the same, but be able to understand a little bit the kinetic differences between the 3, because that's the biggest thing to remember with them. Intermediate acting are going to be insulin NPH, which is brand names Novolin N or Humulin N. Regular insulin, regular insulin is just synthetic human insulin. It's the exact same. It's made in a lab, but it's the exact same thing you would get endogenously if you look at like how the protein structure or the peptide structure, I should say, is built. Rapid acting, there's 3 products on the market there: Aspart, Lispro, and Glulisine. And then again, the concentrations are generally 100 units per mil. And we'll come back to all these in more detail here. If you're wondering what the onsets look like, so if you're non-diabetic, your pancreas is going to shoot out some insulin, and it's going to be in the bloodstream essentially immediately. So it's basically 100% bioavailable right away. Everything else is sub-Q injections. You can give regular insulin like the short-acting would be the yellow one. This is a sub-Q, but you can give regular insulin IV if you need to. So in like a hyperglycemic crisis, you could do that if you wanted to, and that would be a much faster onset. But this is all looking at sub-Q. So really mimicking physiologic insulin is very difficult to do with the sub-Q process, but we try our best. So you have a lot of different options here. If we look at the long-acting ones, they don't have a very fast onset. You can see it's sort of gradual. But if you're taking them every day, you think about this time being bridged. So essentially, you've got a basal rate that's continuous. You never really have a dip there. When it comes to the intermediate actings, you can see a pretty big peak to trough window, and then you could bridge that if you wanted, but it gets a little more tricky to do that in a way that doesn't cause hypoglycemia and gives your patient the insulin they need regularly. Rapid actings, you can see, are very fast on. They only last a couple hours too. Again, mimicking that endogenous insulin burst that you might get at a mealtime. And then there's a couple different premixes, which we'll talk about too, that basically combine intermediate acting with a fast acting. So that's why you see this two-phased kind of bump here. You see the rapid acting going first, and then you see sort of another peak as the intermediate acting kicks in after that. So those are rare to use, and it gets a lot more complicated, but they are on the market. In case you like a chart to look at how everything works and the hours and everything like that, I'm not going to test you on any hours of onset or anything, but I do think it's good to have a reference like this on hand, especially if you dose insulin, or if you work in an emergency department or urgent care. It's a pretty common presentation as people who accidentally use too much insulin, or maybe they've been sick and they haven't down dosed their insulin, so they haven't been eating as much, but have been using the same amount of insulin, and they come in super hypoglycemic. So it might be nice to know, have a reference like this to say, okay, somebody took too much of their Lispro at breakfast. How long is that going to sit around in their body before I have to get concerned? All right, let's talk more about basal insulin. So again, there's three different types of these. Glargine is the most common, and it's been on the market not necessarily the longest, but it's been, as far as consistent no peak insulin, is if we go back to our thing here, the long-acting, Glargine really doesn't have much of a peak at all. It just sort of flatlines and then stays high for a while, and then it'll sort of gradually taper off. And then again, if you're dosing it the next day at about 24 hours, you're going to get basically the equivalent, never having really a drop or a peak in it. And that's really ideal for basal insulin. Again, pretty predictable. There's a couple different products on the market. Lantus and Basaglar are basically the same thing. They're essentially, think of one as different brand names of each other. Toujeo is a newer Glargine product that's a concentrated formulation. So when I say U100 or U300 or U100, that's how many units per mil. So U100 is 100 units per mil concentration. U300 is 300 units per mil concentration. So the Toujeo product is for those patients. Now, generally, these are type 2 patients who have really poor control, who are on really high Lantus doses, or Glargine doses, I should say. But again, if you're on like 100 units twice a day of Glargine, which is a lot, it might be better for you to be on a more concentrated product. One, you're going to get longer use out of the pen. You aren't cycling through quite as many pens. And two, it's going to absorb a little bit better because it's less volume. And it's going to get into the subcutaneous space more effectively. Tresiba or Degludec is a product that's a newer one. So this actually came out within the last couple of years. So it's one of the newest insulins on the market. It's a U100 and U200 product. So you get a couple different concentrations. It's got a little bit longer of a half-life than Glargine. Anyway, you see 24 hours there. It does take a while to get it up to steady state, but a lot of people, I don't know if I want to say a lot of people, there's some growing trends in diabetes expert thought process to say that this is a better product overall because it has a longer lasting and it's easier to keep it steady, versus some people have issues with Glargine where they have to take it twice a day or take it at certain times a day because they do experience kind of a dip and a trough with it, whereas with Degludec we don't see that quite as much. So really what the metric here is this bottom bullet point here, lower nocturnal hypoglycemia. And so if somebody takes Glargine first thing in the morning, that might be wearing off a little bit by the time they go to bed in some patients. Now, not in all patients. So that's why it's predictable in most people, but not always. In this case, we don't clinically, in clinical trials, I didn't see quite as much nocturnal hypoglycemia happening in patients on degludec versus glargine. So some people will say, well, you get less side effects with it. You have a longer acting, so it bridges you all the way until the next morning injection. Now, you can get around that again by doing glargine twice a day if you do it at morning and bedtime. So some people will do that, and that's fine. But for people doing it once a day who are struggling with that and don't want to do more injections, the degludec might be a nice option. Detamir is I think it's actually one of the first ones, so it's a little bit older. It's very dose dependent, so if you give more, it tends to have a bit of a depot effect and leach out slower, so its kinetics aren't quite as predictable as glargine or degludec, and you end up with usually a twice daily regimen for people on Detamir, so you can't go once daily with that, which makes it a little bit inconvenient for some people. And overall, it's less predictable, so we don't like it quite as much for basal, but some people will take it still. I do see it prescribed every once in a while. I think the other two are going to be the preferred options in most cases, but Detamir is still on the market for sure. Switching gears to our rapid-acting insulin, or our mealtime insulin, you have glulisine, aspart, and lispro. Basically, these are all the same. They're all interchangeable. There's no one that's better than the other, and they all have essentially the exact same kinetic profile, which makes it really easy. Basically, your insurance is going to tell you which one they want you to prescribe, and that's the one you're going to prescribe. That's really what it comes down to. There's a couple differences with Humalog. That's a brand name of insulin lispro, and that's U100 or U200. So there is a more concentrated version out there with just the Humalog brand product, which again is lispro. Insulin gets tricky because most people talk about them in brand names, Humalog, Novolog, etc., Lantus, whatever it may be, versus the insulin, glulisine. But it's good de novo, just like anything. All right. We'll talk about a regimen here in a couple slides, so hold your horses if you're wondering how do you dose these things. Choosing insulin, so some other options we have NPH, which I talked about already. I think I'm not even going to remember. It's protamine Hagoderm. I can't remember what the N stands for. Anyway, it's some guy who made a specific chain on the end of regular insulin. It lasts a little bit longer. It's a twice daily insulin. And again, this is one that's relatively inexpensive compared to the other one, so that's really going to be its major advantage. Sometimes you might see people on regular insulin like 3 to 4 times daily, and that's going to be probably the cheapest regimen. Regular insulin is relatively inexpensive. It does come in 2 different concentrations as well, so there's a U100 and a U500. U500 insulin is 500 units per mil. If you know anything about insulin, so one of our biggest risks here is overdoing insulin, right, with hypoglycemia, so bottoming out somebody's sugar. U500 is probably one of the most dangerous drugs on the market because if you dose it wrong even a little bit, you can overdo it so substantially that you can put somebody into a really significant hypoglycemic situation. So we treat U500 insulin like, a controlled substance at our hospital. It's locked up in a narcotic vault. You have to sign it out. You have to double document it and double sign it for nursing and for pharmacy when we're preparing it or administering it. So it's something we take pretty seriously. So I just wanted to throw that out there. It is a nice option, though, for people, again, who have really high insulin requirements and are on a regimen like this. It gives them a lower volume to inject. And again, it's relatively inexpensive compared to some other choices out there. The most common regimen you're going to see is going to be like a Levemir glargine or plus a Novolog, which is going to be your rapid-acting product, and that's going to be either once daily or twice daily, though. So that's pretty much going to be what people are going to do. Mixed combinations, I mentioned these again. I don't want you to know these for the exam because it gets really confusing. But just the one thing I'd probably say from a prescriber point of view is when you're prescribing insulin, really double check what you're writing in your prescription because it's really easy in an electronic medical record to mess this up. So maybe you put in, you want to prescribe just plain Novolog, which is insulin aspart, and you accidentally type in Novolog, 7030, and that one comes up and you don't realize it was that one, and they end up on a different insulin than you wanted to, which could have potentially disastrous consequences. So just always double check that because the combinations and the brand names all sound really similar, and just make sure you're giving them exactly the one that you mentioned. It's always worth a double check on this stuff. But again, there are a bunch of combos out there. How frequently are they used? It's a rare, I would say it's much more rare to see a combo product versus a more traditional long-acting plus just plain rapid-acting. All right, designing your initial regimen. So for somebody with type 1 diabetes, you usually approach it from a weight-based perspective to start with. So 0.2 to 0.4 units per kilogram per day. Teens might need a little bit more, and eventually you might need to titrate up to like a 0.6 to 0.7, but we never want to overdo it right away because that puts them at risk for hypoglycemia. It's better for the body to tolerate a little bit of high blood sugar than low blood sugar, right? So if we have the choice, we always want to pick high. So if you're trying to get somebody's blood sugar down, it's okay to do it gradually, unless they're like in diabetic ketoacidosis and really in an emergency situation, that's different. But for the most part, when a patient presents initially, it's okay to take a more conservative approach. They need to be able to check their blood sugar measurements daily, so that's another important thing to set them up with is meters and test strips so that they can adjust their dose based on how they're responding to the regimen. Essentially, when you figure out your total units per day based on this weight-based calculation, you're going to divide that in half and give half as basal. So you give half as glargine, for example, and the other halves are going to be split up around the mealtime doses. Mealtime insulin is sort of all over the board as far as how people do it. There's right ways to do it and less right ways to do it, in my opinion. And what you decide is probably going to depend on how adherent your patient's going to be and how willing they are to take advantage of some of these more complicated scenarios. But certainly there are better ways to do this. But sliding scale is something that's really common. Here's just an example of a basic sliding scale. So at mealtime, you might tell somebody, okay, check your blood sugar. If it's within these ranges, you're going to give this much insulin. Pretty straightforward. A fixed dose is simply just saying take 10 units per meal, every meal, and something at bedtime, and that's it. So there's no sliding scale. You check your blood sugar, but you don't adjust based on that. So that's obviously not as good for a number of reasons. There's no flexibility in that. Carb counting would be having your patient probably meet with a dietitian and go through how to carb count and some education on that. But basically 3 units per carb choice. And then what is probably the most common and best way to do it is a carb counting plus a sliding scale. So the patient carb counts for each meal, and they do however many units. I just put 3 in here as an example. It could be 5, it could be 2, whatever it might be. So let's say they're doing 3 units per carb choice. Their meal contains 3 carb choices. They're going to do 9 units. And then at their meal, they check their blood sugar, and it was 200, so they're going to add 1 unit onto that. So they'd give themselves 10 units. Yes?
When you say carb choice, do you mean like different kinds of carbs or amount of them?
No, it's like the amount. So different foods have like a different carb, what they qualify as like a carbohydrate choice. There's probably apps out there. Has anybody experienced this with like using an app or something like that?
Well, it's a 15-gram carbohydrate choice
Okay.
is a carb count. So, I mean, that's different than a slice of bread versus whatever. So it's however many total carbohydrates are in food item. 15, whatever it is one carb choice.
So like a sandwich might have 2 carb choices.
Yes.
Yeah.
Mm. And again, ability of patients to do this. Carb counting plus sliding scale is 2 variables they have to calculate with every time they use their insulin. So again, it depends on how competent the patient is really, or how competent their caregivers are to be able to do this. But carb counting plus sliding scale is the gold standard really when it comes to mealtime. The rest of it is options to consider if that doesn't work. Monitoring blood glucose. Different systems are out there. They all basically do the same thing. They're going to check a blood glucose and give you a nice readout for what it is. There's a lot of different interesting technology developing now. There's wireless meters that just basically hook in for like a few days or something. Each one has, depending on the brand, they have different durations, but they communicate Bluetooth with your phone and will kind of check periodically for you. I have a technician I work with who's got one, and he's like, oh, my blood sugar's 55. Do you have any candy around? I'm like, what? So yeah, but it's nice to know versus having to actually like prick your finger and remember to do that. So technology is really increasing nicely in this area, and we're getting to the point where our technology is almost like an artificial pancreas. Really, you have a monitor that's telling your phone information, and then you can also have some things that communicate back to a pump, and that's sort of a little farther out there. We aren't quite there yet, but I think that's the way technology is going. So tests 4 to 7 times a day usually is what people are going to do: morning, bedtime, meal times, and then if they're exercising, that's pretty common. Depends on what they're doing throughout the day. Single blood sugar is only a snapshot, so it's really important to look at trends. Most meters you can check and see a bunch of trends, and again, a lot of phone apps have things that sync up to the meters now, so you can look at somebody's phone and trend it all that way. Hemoglobin A1C is, of course, our metric for type 2 diabetes and what we're looking at. So that's really a snapshot of blood glucose over the past 2 to 3 months. We don't really care about A1C with a type 1 patient. It's not as relevant because it's not a metric we follow. We're just trying to keep their blood sugar within normal realm, right? They aren't usually presenting problematically because we're trying to stop them from having chronic hyperglycemia. It's because we're trying to replace their insulin. So a couple different strategies there. But just I thought I'd put that in there as far as how it compares to monitoring. Continuous infusion pumps are usually filled with rapid-acting insulin, so that'd be your Lispro or Aspart probably. Glucine technically could be used as well. And it will provide a basal rate of some sort, plus the ability to bolus during meal times. The initial pump dose is usually about 10 to 20% less than somebody on an injection regimen. So if you convert somebody from an intensive regimen to an infusion pump, you're going to go down overall in insulin because it's more efficient to do it this way. You can adjust the rate for different times of the day. There's a lot of different settings you can do with pumps, so I'm not going to get into them all because it gets a little complicated. But essentially, it does require a fair amount of compliance. I think people think, well, pump would be easier because it's sort of set it and forget it. And it's kind of the opposite. You have to manage your pump pretty carefully. You have to be on top of your blood sugar levels and be able to adjust your pump and use your pump correctly, and also know if your pump's malfunctioning. So we get people in the ER with malfunctioning pumps every once in a while, and usually it's a call to Medtronic, but there's other things involved with it too. So have anybody read about people who are like buying old Medtronic pumps and like kind of hijacking the radio frequencies to be able to use them with some pirated apps of sorts? It's kind of cool. Cool in a way that people are pretty what's the word? Yeah, tech savvy. There we go. That's a good way to say it. People are getting tech savvy enough where there's some older Medtronic pumps that they're able to actually tap into the frequency, and some guys figured this out, and he posted a guide on the internet. Now the problem, so the purpose for that is that the pump can communicate directly with your blood sugar monitor. So it's essentially working in a closed system that way, and it's all talking to each other. We aren't quite there yet. Obviously, pump manufacturers want to do that, but they have to go through things like FDA clearance for improvement like that. So that gets a little complicated. And so there's interesting stuff out there. So don't be surprised if you see some patients doing things that are a little bit rogue and not necessarily approved by the FDA. Hypoglycemia. So we've talked about this. This is really the only side effect to insulin therapy, with maybe the other thing being some injection site reaction potentially. Blood glucose less than 70 for most patients. And again, insulin is a really high-risk medication. If you look at a breakdown of why people report to emergency departments and then look at a subset of those that are medication-related, most people report for issues revolving anticoagulation or hypoglycemic agents, and insulin being one of the most potent hypoglycemic agents. If you overdo it a little bit, you can go hypoglycemic pretty quickly. Usually you consume 15 to 20 grams of glucose or some sort of simple sugar. There's specific products on the market made to do this. There's gels that are fast-acting glucose that your body can just use them. They're more simple and broken down versus like if you ate a candy bar or something like that. In severe cases, hypoglycemia can result in coma, seizures, and cardiac arrest. And so that's something, of course, we want to be really cognizant about, making sure we're managing this aggressively. Again, if you have to bump somebody's sugar up above what would be the goal window for a little bit, that's not a big deal. It's a big deal when it drops too far. Yes.
Do you have a number for like when it causes?
No, it depends. I mean, I've seen people in like the 30s with pretty bad side effects, and also people in the 30s who are okay. So it kind of depends on the patient. But yeah, once it gets below 50, as an emergency medicine pharmacist, that's where I would start to get really concerned. Patients, yeah. But it does depend on the patient. There is an IV form of dextrose that you can inject. It's like an amp of dextrose, and it works pretty quickly. So it's relatively easy to treat. You just have to be available to have the access to the medications or sugar sources you need. Glucagon is an option that's both an emergency thing and something else you can use for a number of other situations. But basically, it's a peptide hormone produced by pancreatic alpha cells, and endogenously, our bodies would release this if our blood sugar gets low. But again, the pancreas is destroyed in a type 1 diabetic patient, so this is a synthetic version that's on the market. It comes as a little kit like this, and it's got a syringe that you can drop the product in, and you can give it IM or sub-Q. The nice thing about this is it works pretty quick. It's not as good as giving somebody an IV amp of dextrose, but it does work really fast for having a very small profile product. So you can put this in a purse. It's, the box is probably about yay big, so you can put it in. You can carry it around with you. Versus an amp of dextrose is 50 mils of solution. And first of all, you can't give that IM or sub-Q, and second of all, you can't really carry that around with you very effectively. So this is going to be a bit faster in an emergency situation than oral ingestion of some sort of sugar form. So you can certainly do both, but the glucagon is designed for that emergency purpose. DKA is when blood sugar gets extremely high with some presence of ketone bodies and then other side effects associated with it. So diabetic ketoacidosis is usually elevated blood glucose, but it's usually somewhere below 800. Once you get above 800, that's usually the next slide we'll talk about here in a second, so I don't want to confuse them right away. But you can really have it not like a firm cutoff or anything, it's just general. The treatment, basically, if somebody does get diabetic ketoacidosis with super high blood sugar, you're going to look at fluid replacement and then insulin. Usually we're giving IV insulin in these patients with relatively high doses, usually some sort of a bolus dose to get them insulin on board right away. They're probably going to get an insulin drip over time. We'll talk about this more during emergency medicine this summer, but I just wanted to bring it up now in case you're wondering what happens to these patients if they don't use insulin, and type 1 diabetics will go into ketoacidosis if they don't take any insulin eventually. So that's what might be seen if somebody's really non-compliant, or if somebody has a history of, or maybe a new onset potentially, even if it's been undiagnosed for a while. Hyperosmolar hyperglycemic state, or HHS, is the other side of the equation. This is more common in patients with type 2 diabetes who are uncontrolled, and the blood glucoses can get over 1,000 in some of these patients. It's really the same treatment as DKA, though IV insulin is pretty much the standard. All right, you may want me to go over anything else about insulin before we move on to type 2 diabetes. Yeah.
So when you have somebody on, it's regular insulin all the time, you got your basal and your spikes, is there a rate at which that person could develop insulin resistance?
For type 2, yes. For type 1, I don't think so. Generally speaking, I think the body can still respond to the insulin pretty well. Certainly it's possible, depending on how long they've gone in a hyperglycemic state, because that's where you usually get resistance in the surrounding tissues to insulin in general. So whatever insulin the body is still producing isn't enough, but it's also having a resistance because of the high blood sugar levels. And so, but generally in type 1, you don't see as much insulin resistance. Usually once they're on like a pump infusion rate that's working for them, you can pretty much set that and go with it for a while. You don't have to adjust it quite as much, unless they change their diet or their exercise or something like that. It's more lifestyle modifications where you'd have to consider swapping it versus insulin resistance over time. In type 2 patients who have already been really hyperglycemic for a long time and they have tissue resistance to insulin, then that's a problem because you might have to keep pushing the insulin higher and higher and you might not get as good of an effect from it.
You don't have to increase insulin dosages in type 1.
Not usually, right. It's not always, but yeah, you usually should be able to set the dose and go with it from there. All right, this is my funny joke for the day. I think about like type 1 diabetic patient. They're generally kind of have a leaner build. Type 2 patients, usually it's sort of living a rich lifestyle for a long period of time. All right. Type 2 diabetes can certainly be compounded effects from a number of other things such as high blood pressure, smoking, lifestyle, being overweight, and having high cholesterol levels, as I've already said. Essentially, you've got too much sugar floating around the body, and it causes end organ damage. I think of sugar like little pieces of small particle matter that, you know, in the grand scheme of things, if one of us gets a little bit hyperglycemic and some extra sugar goes to the kidneys once or twice here or there, doesn't really matter. And somebody who that's chronically happening, it wears down the blood vessels and the microvasculature over time. That's where you get the complications. I'm not going to talk about the difference in sugar or how to reduce your risk. Certainly exercise is a good thing to do, and we'll talk about that here in a second. Body weight just shows that people with an increase in whatever they defined as desirable weight in this particular study had impaired glucose tolerance. So weight reduction can help in diabetes management as well. It's a really common disease, as I probably don't need to tell you. It affects about 8% of the U.S. population, but there's an estimated that 25 to 40% of type 2 diabetics are just out there undiagnosed. 90% of diabetic patients are type 2 if you're looking at the whole pool of 1 versus 2. Normal labs, what we look at for measuring blood glucose is less than 100, and then A1C less than 6.5. It depends on the guidelines you look at, but that's the most common one. Screening criteria, again, A1C greater than 6.5 is going to be a hallmark give away that your patient is either in pre-diabetes stage or diabetes and needs some treatment. Blood glucoses on their own aren't a huge thing that we care about. Now, if they have a fasting blood glucose over 126, that's something that you'd want to retest, but it's really the A1C we care about, because remember, that's like a 3-month window of blood glucoses all at once. If you're wondering what hemoglobin A1C is and what it means, I don't know if you guys have talked about this before, but briefly, the heme molecule binds blood sugar, so it's really how much blood sugar is bound to hemoglobin, and the higher the percentage, the more blood sugar floating around. As far as goals go, I just put this up here for your reference. There's 2 major guidelines that make treating type 2 diabetes a little bit complicated because they don't always agree with each other, and they're both pretty respected guidelines. So there's the ADA, which is the American Diabetes Association, and the AACE, which is the American Association of Clinical Endocrinologists. And they have slightly varying goals. I would say AACE is a little bit more aggressive, especially if you look at like comparing pregnant patients and what their goal A1C would be. But overall, it's pretty comparable as far as, you know, where they're putting their different goals. And that's probably the biggest outlier I could see here. So non-pharmacologic options, I think certainly diabetes can be managed non-pharmacologically, but it does take a good dedication to be able to do this. And a lot of patients are just not going to be able to do it, or they're going to fall short in some aspect. Doesn't mean it's not good to augment their therapy, but it's certainly not something that's going to be, at least from a clinically studied point of view, unfortunately, diet and exercise just don't have lasting benefits, and people can't keep up with them over time. Now, I'm sure we've heard success stories here or there. I have personally. I had an old boss who got his A1C down from like 13 to 6 on just diet alone. So it's possible. I think he took some metformin too, but he just didn't tell me. I won't say that. But anyway, so weight reduction, diet, exercise, certainly. But for example, there's a study out of the UK that looked at a specific diet. Now, I'm not a dietitian, so I don't really know how this makes sense or not. But basically, only about 3% of patients achieved fasting blood glucose goals. There's not necessarily that we've studied all the right variables when it comes to diet and exercise. And again, I'm not going to get into that. But from the studies that are out there looking at just dietary programs alone, they've shown that it just doesn't improve diabetes 2 treatment long term. So basically, you know, if they can get there with that, that's great. And really, it's all about the A1C. If they can get that down with just diet and exercise, that's fine. But a lot of patients are going to need medications as well. Okay, metformin. Metformin is the nice center point between all the guidelines. Everyone agrees you start metformin right away. So this is always your first line option for type 2 diabetes, sorry. I should mix up my diabetes here. Mechanism, basically, does a couple things: decrease hepatic glucose production, decrease intestinal absorption, and increase peripheral glucose uptake and utilization. The really important thing about the mechanism is it doesn't do anything to increase insulin output. So it's not working in the pancreas to force more insulin. And the reason why that's important is a medication that doesn't mess with your body's output of insulin isn't going to really have any risk of causing hypoglycemia. So metformin is not only one of the more effective oral medications out there for hyperglycemia, it's also one of the safest because it really doesn't cause hypoglycemia. Now, maybe some transient blood glucose drops, certainly you're going to want to see that in your patients because that's how you get your A1C reductions. But having a spike in hypoglycemia is going to be basically unheard of just on metformin. So really, it's first-line therapy for that reason. It has very solid A1C reductions on its own. Contraindications, it does have a new estimated GFR less than 30 mils per minute, which is sort of a new, we've always talked about kidney function in terms of creatinine clearance, and there's some recent data on metformin that looked at GFR instead of creatinine clearance. So anyway, their GFR goal is less than, if your GFR is less than 30, it's contraindicated. It is kidney cleared, and so you can have some excess damage potentially with that. If you have contrast media as well, that can affect the way that the metformin is processed in the kidneys, and you can have renal toxicity with that as well. So usually if you have somebody going for some sort of like a CT contrast, you would hold metformin around the procedure. And you can always restart it, but usually it's held for a few days prior. The side effects, really, lactic acidosis is sort of the rare one that can be associated with severe dehydration, severe infection like sepsis, or hypoxemia. It's really rare and debatable, and there's not really any direct evidence that metformin by itself causes lactic acidosis. So that's all I want you to know about that. But really what patients are going to experience, it's going to cause them to make or break metformin, is going to be the GI-related side effects. So it does cause some diarrhea, maybe some nausea, about 10 to 50% incidence. What I'd recommend for metformin is always starting a patient on the extended release product. It comes as both an immediate and an ER. The ER is just as cheap as the regular. They're not brand name. This drug's been around forever. So there's no real reason to give somebody regular release metformin that I can think of. Give them the extended release, and hopefully that'll help the GI symptoms a little bit better than the immediate release product. All right, next class, sulfonylureas. Sulfonylureas are one of the other sort of historic mainstays in oral hypoglycemic agents. And you see the first mechanism here is stimulate insulin release from beta cells. So the first thing that should ring a bell in your head is that causes hypoglycemia. Sulfonylureas are pretty effective medications. They reduce A1C by 1 to 2%. However, they do have some diminishing returns over time. And they've historically been considered the second-line therapy. So basically, you start somebody on metformin. If you need to add another med, you add a sulfonylurea. However, this has been challenged significantly in the last couple of years, and people are disagreeing with this in different guidelines. And the reason is because there's a school of thought out there that says that if you're forcing the remaining beta cells to overproduce insulin, ultimately you're going to cause more damage long-term than good. And anything that's affecting insulin therapy not only has that problem with it, but it also puts people at hypoglycemic risk. So it's got two strikes against it. So there's a lot of people that are moving away from sulfonylureas as we get newer medications out that are having some interesting new benefits associated with them. Sulfonylureas are kind of taking a back step, but they're still really common. You're going to see them prescribed to a lot of patients. Again, side effect major one is hypoglycemia. They also can cause weight gain, which is sort of interesting. And usually in these patients, weight loss is the preferred option here. They all start kind of with G's. They don't really have a similar name, unfortunately, but glipizide is probably the more common one you'll see. The nice thing about glipizide is it doesn't require any renal adjustment, so patients with poor kidney function. Metformin is probably not going to be an option because of that GFR requirement, but you could give glipizide. Glyburide and glimepiride are both renally adjusted, so they don't get used quite as much. But essentially all these are the same thing. They're just slightly different kinetics. And they all come in some different formulations too. So glipizide comes as a regular release, extended release. Glyburide and glimepiride also have similar different dosing strategies as well. Next, the thiazolidinedione class is pioglitazone. Really is the only one on the market right now that's technically viable. However, some European countries have actually pulled this from the market due to certain cancer risks. It's still available in the U.S. There's another drug on the market called rosiglitazone or Avandia, which was removed in Europe and highly restricted in the U.S. due to perceived myocardial infarction. However, the FDA actually reversed this in 2013 due to some new evidence, which probably made the company super happy about losing out on probably billions of dollars in revenue over years, because pioglitazone was a pretty popular medication. The mechanism is a PPAR gamma agonist, and it activates a gene involving glucose and lipid metabolism. It improves target cell response to insulin. Side effects, doesn't really have any hypoglycemic side effects associated with it, which is nice. A1C lowering benefits aren't quite as good as metformin, but they're not bad either. However, weight gain, fluid retention, and bone loss are all pretty big negatives in its book. This is a class of medications, and we can just say pioglitazone because no one really takes rosiglitazone. So pioglitazone in general is one that just isn't used a whole lot because there are better options out there. And its side effects aren't bad, but you're pretty much eliminating any heart failure patients from being on this medication, and anyone with cardiovascular risk as well, you'd probably want to avoid it. So they aren't used quite as commonly as they used to be. Yeah, there's not a lot of nice, catchy class names for these hypoglycemic agents, unfortunately. I don't really have a good way, other than just, like, people call these the gliptins because they all end in gliptin. But they're DPP-4 inhibitors, which is dipeptidyl peptidase 4, which activates incretin hormones. These are a sort of newer class of medication, but they've been around a while. We know what to do. They have pretty modest A1C lowering effects. However, they have good synergy with other options on the market, so specifically metformin. So you might get 0.4 to 0.6% by itself, but if you combine it with metformin, it's probably not additive. It's probably maybe you get more like 3% total reduction. So you can have some nice effects. These are pretty popular medications. Most of them are pretty expensive. Januvia or sitagliptin is the oldest one, and it's generic now. It's probably the one that's most commonly prescribed. Low hypoglycemic risk, pretty well tolerated overall. There's some FDA issues with joint pain and things like that, but it's minimal. Also, for patients with heart failure, they saw an increase in hospitalization, so probably want to avoid it in those categories. But other than that, for most patients, this is a nice option to try in addition to metformin. SGLT2 transporters, or sodium glucose cotransporter. The mechanism actually, or the name actually sounds exactly what the mechanism is. These basically just help the body excrete glucose in the urine. That's really all they do. These are the newest category of oral hypoglycemic agents. You've probably seen advertisements for these. It also means they're expensive. And I've got a lot of stuff on here because they've got some interesting side effects and some interesting benefits to them. So basically, you're reducing resorption of filtered glucose, you're excreting more glucose. They are renally adjusted. Your kidneys have to work well for these medications to work. So for somebody with poor kidney function, don't even consider them. However, for a younger, healthier patient who's maybe got early onset type 2 diabetes, might be a good option because there really aren't any other side effects associated with it. And if their kidneys work well, there's not really too much of a risk with them. Now, there are a bunch of weird side effects with these, and what I'm really going to point out are the ID-related ones. So if you think about anything increasing sugar in that area of the body, in the genital urinary tract, you can have increases in urinary tract infections, fungal vaginosis, balanitis in men. All those things have been seen. So that's probably one of the most commonly reported complications with them. There's also some other odd things like increases in LDL and bone fractures and stuff like that. Not really exactly sure. However, on the flip side of that, they've seen with more long-term studies on these medications positive mortality benefits and positive cardiovascular benefit outcomes. So for people with CV risk, these drugs are actually becoming almost a first-line option. So for heart failure patients, these are starting to become required therapy because of the benefits associated with them, which is interesting. Separate completely from their diabetes. So it doesn't matter if the heart failure person has diabetes or not, they're going to be on one of these now. So that's a newer thing that we're starting to see. GLP-1 agonist or glucagon-like peptide. Again, the name kind of sounds like what it does. It's a glucagon-like peptide, acts like glucagon. There's a couple different products on the market. These have been around for a while, but more recently we've been getting better at producing them in more convenient forms. So the mechanism, basically, they increase glucose-dependent insulin secretion. So it's an insulin-forcing medication. It's going to have a hypoglycemic risk. It's a sub-Q injection. It's a kind of an odd biologic product that was actually developed from the saliva, or it's not the saliva, but the venom from the Gila monster, the Mexican beaded lizard. And so it's not cheap to make this. They're usually quite expensive as far as the whole medication goes. And these aren't oral, so you have to inject them, which is another problem. So if you've got somebody who's saying, well, you can treat my diabetes however you want, but I'm not injecting anything. I'm not doing insulin. I'm not doing anything else injection. Well, then that patient's not going to be a candidate for these. However, they are decent. They have okay A1C lowering capability. The dosing schedules are variable. So you have the long-acting products, which can be anywhere from like once a day to once a week. The long-acting ones are generally, from what I understand, preferred over the shorter-acting ones. They have better long-term benefits with them associated. Side effects, yes?
So, do they have, like, these animals in some lab that they're extracting from them?
I think good question. I don't think so. I think they're extracting the venom and they're synthesizing the whatever peptide or hormone they got that they thought was the active product there, yeah. But initially, yeah, they had to find it somehow. So somebody had to extract venom from a lizard at some point and study it. Interesting job. So advantages, weight loss with these drugs is a big one. Most studies would agree that these do promote some weight loss, which is a nice advantage for diabetic patients. The risk of hypoglycemia is there, but it's overall quite low, especially when you compare it directly to sulfonylurea. And then some of these are starting to show cardiovascular benefits as well. So again, when we go back to these drugs, the SGLT2s, some entrepreneuring person at a drug company said, let's test this in a bigger population, see if we can cast a wider net and make more money. And then the GLP people are saying, well, let's try that same strategy as well. So they're seeing if there's kind of a link there, and some of these drugs are early in showing that as well. Side effects, nausea and vomiting, diarrhea, 10 to 50% of patients. They are renally eliminated, and some animals have showed thyroid tumors, but that hasn't really been seen in adults. So really, if you can take the GI side effects associated with these, you'll probably be okay. And that comes down to the long-acting ones, too, are going to be much better tolerated than a short-acting product as far as the GI-related side effects go. All right, meglitinides. Repaglinide and nateglinide are the two agents in this one. These aren't super common. They're both brand only. They're kind of expensive. They have a lowish hypoglycemic risk, but they really only recommend them as a sulfonylurea substitute, like if you have an erratic mealtime causing hypoglycemia, and that's in the ADA guidelines. Other than that, these aren't really used all that often, so I'm going to kind of gloss over them. Maybe like a fifth line option. And alpha-glucosidase inhibitors are really not used at all, so I'm not going to talk about them. But they are an option. I mean, certainly they'd be like a sixth-line option. So, I mean, how many drugs can you put somebody on at this point? But those are there. Certainly insulin is an option for patients too. Historically, the treatment of type 2 is pretty straightforward. It's like you try metformin, you try sulfonylurea. If that doesn't work, you put them on insulin. Or if they're really high A1C to start with, you just put them right on insulin to begin with. However, that's sort of gotten changed up in the past, and I'll talk about that here in a second, what the guidelines are recommending right now. But treatment is really similar to type 1. You do usually basal and then a mealtime regimen for a type 2 patient. It's usually less overall insulin to start with, but as you pointed out, you can get resistance over time, and so people on type 2 on insulin can end up with much higher doses of basal and mealtime than somebody you would ever see with a type 1 patient. And this was sort of an old school core look at simplifying how to manage type 2 diabetes. So basically start out lifestyle metformin. If that's not cutting it, add basal insulin or else sulfonylurea. And if that doesn't work, go to intensive insulin. Or you could go and maybe add some different drugs. Now that's, again, the simplified version of looking at it. The ADA has come out with some newer guidelines to incorporate some of these newer classes of medications. And say, first of all, it's pretty similar to start with. You start patients on some sort of healthy eating, weight control, lifestyle changes, start them on metformin. If they don't get their A1C after 3 months, you consider adding a second agent. And if they started at A1C greater than 9, you would actually start at this stage. So that means you just start metformin plus something right away versus going metformin and then adding something on later. So they're saying that all these medication classes, so sulfonylureas, thiazolidinediones, DPPs, SGLT2s, GLPs, insulin, are all on the same playing field. Pick your poison. It doesn't really matter from our perspective. We think they're all okay. They all have benefits and risks. So from a prescriber perspective, it's tricky because you're like, well, which way do I go? And I can't really give you an answer for that other than that you have to look at the individual risks and side effects of each class of drug. So for example, if you wanted weight loss, you'd want to prefer maybe an SGLT2 or GLP-1 because those have more weight loss associated with them. If you want to avoid any type of insulin promoting agent, you'd probably not want to use a sulfonylurea if you buy into that school of thought. Or if you're old school and you're like, no, sulfonylureas rock, they're the best, let's use them, then ADA says that's okay too. So it doesn't really differentiate with those. Now, it does go a little bit further, and then you say, so let's say you tried one of those options, and then it gives you your different combinations. So let's say you tried your sulfonylurea in addition to metformin, well, then you would add something else. And it's really just mixing and matching all the different classes. There's nothing really here that's different than what you might expect. And again, it's sort of saying you can do any option is fine with us as long as you're increasing their therapy somehow. If you don't get 3 months, then move to injectables purely. So let's say you tried this and your patient's on like 3 different oral agents and still not getting controlled, maybe go straight to insulin is sort of what they're saying in this final block here. And then they've got some other options here. If you do have a patient whose blood glucose is greater than 300 or 350 and the A1C is greater than 10 to 12, you can basically start them on a triple therapy type regimen initially. That's, again, kind of a step up from the last block too. So hopefully no real surprises there. So basically they're saying start metformin, lifestyle changes for everyone. Depends on where their A1C is. So if their A1C is greater than 9, start them on something in addition to metformin at the same time. If their A1C is 10 to 12% or higher, start them at 3 different options at the same time. So again, you might have a patient that balks at that a little bit, but that's what the recommendations are. All right, let's switch gears and talk about the endocrinologists because they're a little different. And they stratify things a little bit more specifically. So they're still going to say lifestyle therapy for everybody and metformin for everybody. So that's the same across the board. Where they're going to change up their strategy is recommending things in order of what they think is the best. So, and their A1Cs are a little bit different as well. So if you're less than 7.5, monotherapy with metformin is great. If metformin doesn't work, go with your GLP-1 next, then your SGLT2. So you can see right away, they really like the newer classes. The GLP-1s and the SGLT2s are ringing bells with the endocrinologists because, again, they're buying into this whole don't push insulin, don't overuse insulin. Insulin sensitivity is ultimately what causes diabetes failure long term. Let's avoid using any insulin regimen until we have to. Yes?
Is that in order of like first line metformin?
Yep, exactly. Yes. So they've actually structured them in order. That's the big difference between the two. If your A1C is greater than or equal to 7.5, then you're on a dual therapy, as you can see listed here. And if it's greater than 9%, you're looking at a triple therapy. Or if there's no symptoms, you could maybe consider dual therapy. So if you have a patient coming in and it's like 12, but they're okay otherwise, you don't necessarily need to go directly to triple therapy. So they've given you guys some more latitude to figure out how you want to treat them. Or you could go straight to insulin at that point if you want to. Generally speaking, there's some similarities here, and the ADA guidelines are just a little more general. They agreed for the most part, but the clinical endocrinologist group has decided that they wanted to give more specific recommendations for what they think is the best and what order you should go in, and that's where they've gone with that. So you can see basal insulin is pretty far down the line compared to what we used to treat, where basal insulin was basically second or third line for a lot of patients. So it's changed quite a bit in the last few years. It's how we treat diabetes too. All right, that's the last slide, but I'm happy to go over that again or take questions. Yes?
Should we be able to differentiate between the different guidelines, or like which one should be?
No. What I want you to know, yeah, good question. I'm not going to ask you to differentiate between the different guidelines as far as an exam question. What I would like you to know is just why somebody might prefer a certain agent over the other. So I might give you a patient with weight loss goal in mind. I might give you a patient who's got heart failure. So you'd have to know which classes are bad for heart failure, which classes maybe have CV mortality benefits. So that's how it direct you towards a second line option that way. Anybody have any other questions about these two guidelines? Yes?
So it's not necessarily like a specific like first line, second line that we need to know for the exam.
Nope. As long as you know metformin for type 2 diabetes is your first line, that's always going to be the case. Unless, I gave you a patient on metformin who maybe had GI symptoms, then you'd have to go to second line. But other than that, I would try and guide you in the question as to which one you might pick. So yeah, just knowing the classes. I'm not going to ask you differentiations between drugs within the class, so I'll probably give you an example of one. But as far as I could tell, I'm trying to think back to those ones. There's not really any differences within like a sulfonylurea, with the exception of maybe glipizide being renally adjusted that I could think of. If you look at all the other ones, they're basically all the same. They're all Me-Too drugs. So all the SGLT2s all the same in my book. All the GLP-1s all the same. I'll give you a long-acting one. I won't even mess with the short-acting one, so you don't have to even know that part. But it's basically just understand the class and know which drugs fall into the class, and then you should be okay for the exam. Yes?
Is someone who has GI symptoms on metformin going to be more likely to experience GI symptoms on GLP?
Not necessarily. It's worth a shot. It's possible they're more sensitive to it, but certainly I'd give it a try. All right. I'll post that quick review, and I think I've got some cases to post as well. Try and get those up tonight.